Malaysian Society of Patient Blood Management, MyPBM, is an organizational affiliate of the BMSS. And the first scientific session today is MyPBM session on the pillars of bloodless medicine. The first talk is a keynote address, Raising the Hematocrit Without Blood Transfusion is Evidence-Based, by MyPBM President, Dr. Yee Yee Yap. Let me give a bio for Dr. Yee Yee Yap. Dr. Yee Yee Yap, MD, is clinical hematologist and president of the Malaysia Society of Patient Blood Management at Ampang Hospital, Malaysia. Dr. Yee Yee Yap is a clinical hematologist who is working in Ampang Hospital, Ministry of Health, Malaysia. She did her fellowship at Haemostasis and Thrombosis in Australia, acquired the FRCPath UK in London, UK in 2020. She's also the president of Malaysia Society of Patient Blood Management, has been practicing patient blood management for many years with Dr. Jameela Sathar, who is pioneer of PBM of the country. Dr. Yap.
Well, thank you so much, Professor Su, for the wonderful introductions, as well as Dr. Jameela. I can see the smiley face of my boss over there. So without further ado, I'll just proceed with, I hope you all can hear me well. So are we talking about this raising hematocrit without blood transfusion, yeah? This will be my outline. I will bring you through some of the prevalence, evidence, and ABC of PBM, and followed by case scenarios. So about the prevalence of our anemia globally, this is actually from World Health Organization. So you can see the figure is quite alarming. It's about 2.9 billion over individual with anemia and micronutrient deficiency. You can see it down there with either with following surgical interventions or non-communicable diseases, oncological, hematological malignancy. And out of all this, 600 over million individuals actually with chronic or acute blood loss or any bleeding disorders, either due to GI bleeding, hemoglobinopathy, coagulopathies. And with these statistics, there are 40% of the children are anemic, ranging from 6 months to 5 years old. And for pregnant women, about 37% of them. And for reproductive age women, 15 years old to 49 years old, there's about 30% of them. So it's pretty significant health burden for anemia. Now, this is one of the clinical and economic outcomes of the Western Australia Patient Blood Management Program that was implemented from 2008 to 2014, which was published in World Health Organization as well, how it actually improved patient outcomes. You can see by the mortality, it decreased by 28%, infection 21%, acute myocardial infarction, stroke decreased by 31%, and even length of stay 15%. And even improving the key program indicators. Your preoperative anemia 21 dropped to 14%, pre-transfusion HB 7.9 to 7.3 grams per deciliter, and a single unit of transfusion markedly increased from 33% to 64%. And the reductions of units of blood transfused, you can see the highest would be your red blood cells, which is 41%, plasma is 47%, and platelet is 27%. And most importantly is we're looking at cents and dollars with this kind of program that's being implemented. You can see the product cost saving up to $18.5 million. And the activity-based cost savings, $80 million to $100 million. It's really, really significant. Now, this is the 3 pillars of patient blood management. My talk will be focusing on pillar 1, detection and management of anemia and iron deficiency, which involves routine detection, evaluation, and diagnosis, or even to find out the cause and management of anemia of iron deficiency as to clinically appropriate management and treatment. Now, this is ABC of PBM. It was actually coined by Dr. Jameela, anemia, bleeding, and coagulopathy for pillar 1. If you look it through, which I know a lot of you are like Professor Su, I hope you'll agree with me, whereby we every time see a patient, we have to go through a very thorough clinical history. Yeah. So to identify what is the cause of anemia. And 90% of the time we will be able to derive the diagnosis. For example, if someone has a dietary deficiency or someone is actually on drugs like antiplatelets or anticoagulant, or whether someone is actually having like acute GI blood loss, for example, like telling you they have any like parectal bleeding or any malignant stools, that will actually trigger whether patients anemia, or even for women with reproductive age, like with heavy menstrual bleeding, yeah, as well as other constitutional symptoms where people will actually ring an alarm bell, for example, like unexplained fever, unexplained weight loss, unexplained reduced appetite, which will point towards malignancy. That will actually, we do not stop investigating the cause of anemia there, but we should find out the underlying um, big C for the patients. And secondly, of course, bleeding. This involves a lot of times, which we are all hematologists dealing with our patients with bleeding disorders. For example, like von Willebrand disease, they always come with heavy menstrual bleeding. A lot of times we just normalize the anemia or normalize the menstrual flow. Oh, this is actually nothing much. But actually, you come and look into it, a lot of these patients presented with severe iron deficiency and iron deficiency anemia, which was not being emphasized on. And underlying cause as well was not being looked into. Either the doctors are not being educated about, or the patients, most of the time in our culture, they would just keep it to themselves. They don't even come for medical attentions. And the third, of course, is coagulopathy that will happen with other bleeding disorder as well, like Glanzmann thrombasthenia, even hemophilia, so on and so forth. Now, this is actually a courtesy requested by Dr. Nathaniel. He asked me to tell you all how to calculate iron replacement. So there are two ways of doing it. One is a Ganzoni formula, which you calculate a total iron dose by the body weight times the target HB minus the actual HB times the conversion factor 2.4 plus the iron of the iron stores. For the iron stores, those less than 35 kilos, we use a 50 milligrams times per kilograms to calculate. And for those above 35 kilos, which most of us are, we just use a round figure 500 milligrams as the iron stores. And for the simplified formula, I find this quite useful. You do not need to remember so many numbers, which is just use a target 30 minus the actual HB times 150 plus 500. The difference between these two formula, the simplified formula will actually help you to calculate more total iron dose in comparison to Ganzoni. Now, this is one of the systematic review and meta-analysis to talk about the safety of IV iron preparations. It has around like 103 trials from 1965 to 2013, ranging over 10 over 1,000 patients treated with IV iron. You can see that it has decreased rate of severe adverse events, and the conclusion actually is not associated with any increased risk of severe adverse events or infections. Now, this is another meta-analysis or trial sequential out of 3,000 over patients from 9 randomized control trials for patients with heart failure that treated with IV iron for iron deficiency. You can see the forest plot down there, where those 1,700 over patients treated with IV iron, the cardiovascular death is mainly favor those with IV iron, and the hospitalization and death as well. It's just basically the controls were just being seen as not much of benefits if we just don't use IV iron to treat them. Now, this is another study as well done by Professor Frosler, the anesthetist in Western Australia, where he used an IV iron perioperatively for blood management as a randomized control trial. So this is an elective surgery for the patients of his that he selected like 72 patients with the criteria of ferritin less than 30 nanogram per mils, transferrin saturation of less than 25%, HB less than 12 for female. He was following the WHO, HB less than 13 for male. So the intervention, what he did, he actually gave a dose of ferric carboxy maltose, about 40 of them, over 15 minutes, for ranging from 4 to 21 days before the surgery. And post-operatively, he actually used the HB 0.5 milligram kind of recorded as 1 ml blood loss 2 days after the surgery. And the other group, on the other hand, will be randomized into usual care, either no treatment, continued observation, oral iron, or even allogenic blood transfusion. And he actually evaluated those kind of patients 4 weeks post-surgery with the laboratory and quality of life. Now, this is a type of surgery of all his patients who went through, which is a colorectal surgery. We name it high anterior resection, low anterior resection, upper GI surgery, gynecological surgery, hysterectomy, laparoscopic assisted as well, compared to the usual care. So it's pretty similar, the both arms of the patient's characteristics. So what he found out that there is 60% of reduction in transfusion rate, whereby the usual care is associated with 31% transfusion rates, whereby the IV iron one is only 12.5. So the impact of treating IV iron alone, just before the major abdominal surgery, for those iron deficiency, it decreased the need for blood transfusion 31 to 12%, as you can see. Shorter length of stay, 9.7 to 7 days, and recovery of HB post-discharge, 0.9 to 1.9. Now, this is my case one. I have a 42-year-old Chinese lady who is a Jehovah's Witness presented with abdominal pain and dysmenorrhea for 3 months and was investigated for left ovarian cyst in January 2019. She went to the private center and was noted to have left retroperitoneal tumor. It's pretty huge, 6.6, 8.2, and 8.7 centimeters. So the gynecology surgeon actually went in and biopsied the tumor, which the HB showed a smooth muscle tumor, either a leiomyosarcoma or a smooth muscle tumor of uncertain malignant potentials. So what are you going to do? Would you just leave the lady behind with the mass? She's having abdominal pain. So a lot of times this Jehovah's Witness in my country, there's a lot of resistance to actually take up this sort of cases because they don't want transfusion. So this gynecology surgeon is the same. So she turned away the patients and the patient come to us. What I did is, of course, I didn't watch and wait. And actually do a full blood count on her. And true enough, she has anemia, do the HB of 11.3. And her ferritin at that time was actually like barely in teens, like 12 or 13. So what is your next step? Would you actually treat her with IV iron? Of course we would, as a Jehovah's Witness. Secondly, would you actually use erythropoietin stimulating agent? This is quite obvious. It's an absolute iron deficiency. In comparison, like those I was talking to you, those with malignancy or chronic disease, I can tell you that sometimes because of the urgency of the operations, because she has a huge mass that require probably surgical removal. So I actually use erythropoietin stimulating agent in this case to hasten the hemoglobin optimization. Of course, last but not the least, transfusing blood is not an option in her. So she was started with IV Venofer 200 milligram 3 times per week and the EPREX 4,000 IU 2 times per week since 9 of May. And I can tell you that even to convince our general surgeon in my hospital, it was quite a difficulty and challenging because, I went through the multidisciplinary team meeting with them 3 times. So the first time I actually went and talked to her, she actually turned me down and said that patient is a Jehovah's Witness because there has been a lot of bleeding. So she's not going to take up the case. Secondly, I went with the patients as well together to see her. She's still hesitant to take up the case. Finally, the third time, I went with the patients together with the Jehovah's Witness and also the gynecology team this time because it may be the gynecology in origin, the tumors, whereby I promised her to get a cell salvage because she said a lot of blood loss. And then after that, the Jehovah's Witness brothers brought in a form whereby it was written as release of liability, which means if the patient happened to have severe blood loss on table and would not be accepting blood transfusion, it would be the patient's own risk. Then only she decided to take up the case. So I arranged a cell salvage. On 18th of June, her HB improved to 14.8 grams per deciliter. You can see in the span of like 5 weeks. Her platelet is normal, white cell is normal, yeah. So the operation was done where initially the surgeon decided for diagnostic laparoscopy, yeah. Then finally she saw the mass is too big, then only converted to midline laparotomy and decided to excise the mass. And post-operatively, I can tell you the story whereby initially it's done by the general surgeon. Like Nathaniel was saying yesterday, it was very important to get a very astute, good surgeon. Where this particular surgeon initially struggled. I was actually there together with her. So I offer to call in the gynecology surgeon, and thank God he came in and managed to find the retroperitoneal tumors that is possibility from the migratory fibroid. And it was 10 times 8.5. And this is a cell salvage that I got. And this is the surgical field. You can see that time was quite difficult. We're still not able to locate and take out the mass. And finally, when the gynae surgeon came in, he just quite slick and he performed I would say that's really bloodless surgery and removed the fibroid in like probably 15 minutes, I would say. And that is a blood loss from him. It's only barely 200 mils, which in my opinion, I think this cell salvage does not even require in the first place. So this is my case too. The 61-year-old Indian lady who is a Jehovah's Witness again with diabetes and hypertension. She has history of non-ST elevation myocardial infarctions with the stent recently and a history of cervical CA diagnosed 6 years ago at a private hospital with the radiotherapy done 4 cycles lastly in June this year. She was treated with double antiplatelets, ticagrelor, and also aspirin for the ischemic heart disease because of the stenting. However, because of the double antiplatelet, she was complicated with gross hematuria. And the HB fell to 3 and was intubated on inotropic support in one of the private hospitals. So that particular private hospital, I had a word with a cardiologist. So he decided to take my advice and treated her with IV iron and EPREX and get the urologist in, did a bedside cauterization and finally stopped the bleeding. Her HB improved and finally discharged from the ICU and from the private hospital. Unfortunately, because of the stent in the coronary arteries, someone decided to start back the double antiplatelets, which she presented with recurrent gross hematuria again 1 week later to my hospital. And that was a HB initially, which was 8 grams. You can see the HB keep falling throughout the days until 3.8. I tell you what happened. So this particular lady initially landed in my another general surgeon colleagues, where he actually wanted to manage himself. But unfortunately, the gross hematuria was keep on quite bad, this lady, until the HB dropped to 3.8, where finally the lady has a recurrent non-ST elevation MI again. And this time complicated with acute pulmonary edema, where he finally really talked to me with a trop T of 1002. This is one of the another iron study markers which you use to measure the immature reticulocytes, the iron content, the 25 picogram, which is less than 30. And her HB at the time you can see 3.8 was pretty low. And he has no means to manage anymore because the lady is having ongoing MI with a low HB and would not accept transfusion. Yeah. So what I did, I basically, thanks to Dr. Jameela as well, we went together to see the lady. The lady was basically, we just supportively helped the ladies with the IV iron, monofer that we gave her together with the EPREX, as you can see over here. EPREX, and also we did actually diuretics as well. I didn't give her any anticoagulant as well as dual antiplatelets because the hematuria was so severe. And in the end, because we even get a help from the Jehovah's Witness brother that managed to find this particular intravesical instillin, which is a hyaluronic acid. And we decided to do with the bladder irrigations as well as tranexamic acid. And you can see the amount of IV iron that we bump into her. 5 cosmophore, 2 monophore, like rhinophore as well. So the moral of the story is actually when there is something bleeding, we just have to stop the bleeding. But because of this lady is a Jehovah's Witness, everybody is so afraid to take her to the theater under the general anesthesia to do the cauterizations, which the private hospital actually did, I managed to optimize the HB to 6.4 when I used these conservative measures to stop the gross hematuria in this lady. You can see over this picture, initially she presented with this sort of really thick that we just clot up the whole catheter bladder drainage tubes. You can see over the time when we started using all these measures, the urine start to clear up. Unfortunately, because the medical said that we need to give at least a single antiplatelets, which we did. After that, she stopped for like 4 or 5 days, restarted by an aspirin. And then 2 days later, she hematuria again. This time even worse. Because she has a right femoral catheter, she developed a right lower limb DVT, deep vein thrombosis. And you know what? This time I had a multidisciplinary meetings together with the anesthetist, the general surgeon, the urologist. The first time round was not successful because the anesthetist say that it needs to be having a HB of 8 before we can put the patient under, because patient is a case of non-STEMI. After that, I of course I don't give up. I keep on talking to the urologist, talking to the general surgeon, try to convince them, please take her. I think the urologist in the end kind of like persuaded by me, transfer her to urology ward in another hospital, and we kind of like taking the middle ground. Okay, fine, she cannot be anticoagulated. So we put in an inferior vena cava filter. And I think she was still hesitant to do the cauterization, for her. So what she did, she was just using the conservative method like what I was using until the hematuria stopped again. But of course, the HB is low. Until at one point, she will hold the CBD. I still remember she called me up, the urologist, saying that, hey, maybe I want to send the lady back to Dipawali. However, unfortunately, once she removed the CBD, the lady developed acute urinary intentions. And she has no choice. Take the lady to the theater under GA, did the cystodiatomy, and she noticed such a huge clots blocking the bladder outlet and the telangiectasia all over the bladder mucosa that contributing to the radiation cystitis or what this lady is having. So she removed all the clots by the urologist, and finally she has a clear urine. And thank God, before she went into the surgery, the HB was 6.5, 6.6, optimized by me. And subsequently, I rescued her in monophore, and now she's extubated and ambulating well with no bleeding. Now, this is my case 3. I have a 47-year-old Malay lady with newly diagnosed Burkitt's lymphoma from ovarian mass with endometrial thickening, in which she presented with abdominal bloatedness and abdominal swelling. This is Dr. Jameela's patient as well. She was initially suspected to have uterine fibroid, then was undergoing laparoscopic removal of the uterine mass. But in the operating theater, noted there was an ovarian mass looked like malignant. So thank God she took it out, and we sent for HPE, and it's a Burkitt's lymphoma, whereby we treated her with 6 cycles of intensive chemotherapy, R block AB, which is basically based on Berlin, Frankfurt, and Munster kind of chemotherapy intensively over the period of 5 months. You can see 6 cycles. So what happened to her is, this is the imaging courtesy from Dr. Jameela. You can see so huge mass over here for the ovarian mass, so to speak. So what we did, I want to illustrate to you basically, even within my own hematology fraternity, I also have difficulty to convince some of my consultants to use IV iron. You can see this lady clearly, that initially she was in the other wards from the 3rd of July until 10th of September, whereby she was being transfused, where the intensive chemotherapy she was undergoing. You can see the HB trend. It was still low, despite the transfusion up to 900 mils. And of course, because of the intensive chemotherapy, she will go into nadir with the leukopenia. You can see the white cell drop to 0.4 and platelet drop to teens as well, which if, of course, essentially will be supported with transfusion of platelets. So what we decided, she's actually a very educated lady. So we convinced her that probably can manage with IV iron and EPREX. And she actually took in the idea and agreed to transfer to the other wards, which is more pro-PBM. So you can see we are using IV iron and EPREX over the time, where she was still undergoing the intensive chemotherapy 3 weekly, that the 6.2, 6.2, 6.4, 7.4, that she was sustained with the IV Venofer weekly and the EPREX 2 times per week, 4,000 IU. And eventually, when she has completed the chemotherapy, and we managed to optimize her HB up to 12.3. So this is what happened to her. After the chemotherapy, she achieved a complete remissions. And I think I can tell you why some of my hematologists are not very keen to use IV iron and EPREX in patients with malignancy, because there is a belief that IV iron would be toxic to cancer patients, number one. Number two, they also believe that the EPREX or EPO receptor may be present on tumors that may promote the tumor growth. But what I can tell you in this particular case, she has done the chemotherapy in 2019, which is 5 years ago. I still saw her in my clinic, and she's still doing very well. Yeah, she's currently holding an important position in one of the government administrative bodies. This is a real case. In conclusion, it is feasible to raise the hematocrit by parenteral iron plus or minus erythropoietin stimulating agent. And of course, identifying the cause of anemia is essential for the appropriate treatment. And last but not the least, empowering the blood health is the way forward. Thank you very much.